I just want to start by recognizing that the police violence over the past several weeks has put an extra burden on a lot of people of color. Bailiff condemns the police violence in the strongest terms possible against the Black and African American communities. And we're calling on our own members to reach out to each other and those affected by the violence. We've issued a statement. We are going to continue to work on looking for opportunities that our members can take to take action. And we welcome any feedback from our members. And please send that to the co-chairs. I also want to make sure people know that this recording or this session is going to be recorded. And if you personally feel unable to attend live because of events going on or for whatever reason, please feel free to drop off of this call and we will make that available after the event. So my name is Jeff Cosby, for those of you who don't know me, and I'm the co-chair of Bailiff. Bailiff is a community of LGBTQI plus legal professionals that envisions a world where LGBTQI plus people live with dignity and equality under the law. And our mission is to lead our LGBTQI plus legal community through advocacy, justice, community empowerment, and professional development. And if you're not a Bailiff member and you are interested, please visit our website or go ahead and email me. It is our 40th anniversary year, so it is a great time to join Bailiff if you are interested. As I already said, we are recording this, and I think I have only the presenter's video on. If you're not a presenter, I do ask that you turn your video off for now, just so we can make sure we're capturing the presenter's screens. I will share the slides post-meeting. And to the presenters, I'm going to do my best to advance slides as appropriate, but please signal me if I miss one, because I'm sure I'm going to miss advancing some of your slides. I've truncated some of these bios for time's sake, but just very brief introductions. We have Monica Gandhi, who's a professor of medicine in the Division of HIV, Infectious Diseases, and Global Medicine at UCSF, and also serves as the director of the UCSF Center for AIDS Research and the medical director of Ward 86. And she will serve as the co-chair of AIDS 2020 Virtual in San Francisco, Oakland in July. We have Andy Scheer, who is a bilingual medical social worker for the San Francisco Department of Public Health, where he supports clients with entry and re-entry into HIV primary care at SF City Clinic. He's a co-founder of the SFHIV Frontline Organizing Group, which is a grassroots effort to build capacity among client-facing workers in their navigation of clients through complex HIV systems of care and public benefits. We have Bill Hirsch, who is executive director of ALRP, where he has served as executive director for the last 20 years, overseeing all of its programs and administration. He's responsible for program management, fundraising, financial management, administration of the office and staff, and community relations. And during his tenure, the organization has grown to a budget of 1.8 million and a 16-person staff. And finally, we have Negin Mohajeri. Is that how you pronounce that?
It's Negin Mohajeri.
Negin Mohajeri.
Hi, everyone.
Sorry, Negin is a staff attorney at PRC, and after attending the University of San Francisco School of Law, because of her passion for social justice, she began practicing Social Security disability law, which she has been doing since 2012. Negin joined PRC in 2019 as part of the benefits counseling team, where she has continued her pursuit of helping those in need, especially those affected by HIV, AIDS, substance abuse, mental health issues, and/or housing insecurity. So those are our presenters. And with that, I will go ahead and start the PowerPoint, and we will start with Monica.
Great. So you'll advance them?
Yes.
Okay. So I guess, yeah. Okay, next slide, please. I'm going to talk about the interaction between COVID and HIV. And really what I'm going to start with is the COVID-19 pandemic. What happened? Where did it come from? I'll talk about the epidemic in the United States. I'll talk about the epidemic locally in San Francisco. I'll talk about some aspects of the interaction between HIV and COVID. Why do we think it could be worse? Why do we think it could be better in HIV? And what have we seen in San Francisco and elsewhere for people with HIV and COVID? And then talk about some health concerns for people with HIV, and I'm happy to answer any questions about COVID or HIV. So next slide, please. So actually just like advance it 6 times because it'll bring down these pictures. Sorry. Okay. It's animated. So, you know, how HIV got into human populations and how COVID got into human populations, just a couple more down, is really has to do with sort of what we're doing as humans interacting with the animal world. So we're warming up the planet. We are interacting with animals in a lot of different ways, hunting, eating pets. There have been changes in agriculture. We've encroached onto human and animal habitats. The urbanization with people more crowded together, and then just how fast we get around with jet travel and ships and breakdown of public health measures. These all have led to kind of both HIV and COVID-19 entering human populations. So definitely they are both zoonotic organisms. And next slide, really where did COVID come from? Next slide, please. Well, it's a virus, so viruses can't live on their own. They need a host to help them replicate. And what this coronavirus is, or what is a coronavirus, is the corona aspect really stands for the crown in Latin. That's what corona means. And so the reason that it's referred to as a coronavirus is the virus itself under electron microscope has these little spikes on the surface. And so that's what's given it the name of coronavirus. Usually coronaviruses cause the common cold. So sneezing, runny nose, mild sore throat, mild fever. But there's been 3 times, next slide please, where we've seen coronaviruses get worse and cause essentially more severe symptoms in the lungs, in the lower lungs, or acute respiratory distress syndrome than just the common cold. We had another coronavirus outbreak like this, not like this at all, but one that was at least in the same family in 2002 and another in 2012. So this is the 3rd time, but this is very much the worst time. And let me explain those other 2 pandemics. So next slide, please. So the first one that came out, this coronavirus that caused the acute respiratory distress syndrome, or the more lower respiratory disease, the more pneumonias and could lead to death, not just the common cold, was the SARS pandemic. And that occurred in 2002. It really started in 2002 in November, and it ended by July 2003. So it was very limited. It lasted about 9 months. There were 8,098 cases in the world total, and there were 29 countries that it went to, and there were 774 deaths. So the case fatality rate was high. It was almost 10%, because coronavirus can be, when it causes this ARDS, can be very severe, but it was very limited. And there were 29 cases in the US. There were 0 deaths in the US. There were more in Canada, actually. And the original animal host of this virus, and probably of all the viruses, all 3 that I'm going to talk about, is the horseshoe bat. But then the virus usually goes through another animal before it comes into humans. And in the case of the SARS-CoV, or the first SARS virus, it was probably a cat-like mammal called the palm civet. And then it got into humans, and then it suddenly could be spread human to human. The next slide, please. The second coronavirus that did this was called the Middle East Respiratory Syndrome, or MERS. This came out in 2012. It was caused by a virus called MERS-CoV, and all cases in this case were linked to the Middle East. So the first case came out in Saudi Arabia in 2012. It went around the world actually for the next 7 years, but it was really limited. It was 27 countries, 2494 cases. Again, a high case fatality rate, 858 deaths. And there were 2 cases only in the United States in May 2014, and they were both linked to healthcare workers from Saudi Arabia. Its intermediary host from the bat was the camel, and then it went to human. So the next slide shows what happened with this coronavirus. And this is really, quite different from those other 2 pandemics. There was a first declaration of this new coronavirus on December 31st, 2019, after the coronavirus had probably been circulating in China for at least a month or maybe a month and a half. There was a whistleblower event that led to, because an ophthalmologist had died of this, what was eventually this COVID-19. And, it's unclear, again, the exposure event. There's a question of bats and then animals being linked together in relatively close quarters in what are called wet markets, though we haven't had a direct link to them. At least the intermediary host, the most likely candidate right now is a pangolin, which is kind of an anteater like animal, and a delicacy that in some places. And so unfortunately this animal was eaten. And so, not totally clear, but it looks like that is the most likely intermediary host. On January 7th, this ARDS, or this fever, cough, pneumonia syndrome, was found to be a coronavirus itself. So it was identified as a coronavirus 7 days later. It's been spreading around the world since then. On January 30th, the World Health Organization called it a global health emergency. And on March 11th, the WHO declared it a pandemic. So next slide. This slide really tells us where we are in the world as of today at 5 p.m. Completely different, obviously, as you can see from those limited 8,100 cases with SARS-CoV-2 with MERS. This is now 6 million, over 6 million cases worldwide. And we've had 377,000 deaths. The U.S. became the epicenter of the pandemic on March 26, and we have retained that position since at almost 9 million cases and over 100,000 deaths. New York was the epicenter of the pandemic in the United States. The state still contains a high number of cases, but luckily both New York and New York City, both deaths and cases have flattened out. The Northeast is a major hotspot, and I'll show you the map of the US in the next slide. California, we've had out of 40 million people in the state, 114,732 cases and 4,200 deaths. That is definitely lower than compared to what was happening in New York. San Francisco, we've had a very low number of cases for our population, 2,570 cases. Out of around 833,000 in the city proper, and 43 deaths, which is a very low number compared to what was seen in New York City. Really, essentially, May 22nd was the last time a health ordinance was released, and the health shelter-in-place orders are sort of extended indefinitely, with gradually opening up of various things over time. But there's definitely not a relaxation of the completely shelter-in-place, and these were first put into effect on May 6th. Next slide. So these are the hotspots in the United States. You can see the red areas. So in California, at least, LA has been more of a hotspot, and then you can see the Northeast, but certainly look at what's happening in the South and the Southeast with hotspots coming up over Minnesota and Alabama and Georgia and unfortunately Minnesota, and with what we were talking about today earlier, and how you started, Jeff, with what's been going on with the George Floyd murder there. So next slide, please. So what does COVID-19 in San Francisco look like? So this data is actually updated daily. This is called the San Francisco DPH data tracker. That's how you can find the data in the city. And you can see that we've actually really ramped up testing. We have a lot of tests that have been done in the city, and our test positivity rate is very low compared to the number of tests that we've done. So 68,418 tests. Of that, only 2,570 cases, 43 deaths. It's been a very, very flat curve in terms of deaths. We've been very fortunate, and also we're very aggressive about our social distancing measures. It is a male predominant infection in most places, everywhere actually, including here in San Francisco, 60% male, 39% female, 1% unknown. The neighborhoods that are most affected are shown here in this zip code map that is also updated every day. So you can see the cases are more concentrated where the biggest shelter was, Soma, the Mission after a big testing project, but even before, and in that area near Bayview. So next slide, please. So other things to note about the epidemic in San Francisco is that we are a young city, and it is a young infection. That doesn't mean that so many people have gotten sick, but you can see the skewing of the distribution of cases among the younger people in the city. And then a really, really stark disparity in terms of Latinos being infected in the city. 47.3% of the cases are Latinx populations, even though only 15% of the city is Latinx. So really, really disproportionate impact on immigrant populations, populations that are generally out in the workforce, essential workers, still working during the pandemic, harder to shelter in place, often crowded households. And a lot of those factors have led to this disparity among Latinx populations. Around the country, it really is a population that, it is an infection that is affecting Brown and Black populations disproportionately. And that is adding and fueling the tension that's occurring right now when we're seeing all the systemic racism and the very dire consequences of that over the last couple of weeks. Next slide. So, you know, this is a little history of the city. Remember, March 5th was the first cases of community transmission reported in San Francisco. It was a big press conference. No one was wearing masks at the time. This was a different time. On March 6th, many clinics started developing guidelines on telephone visits. And that's important because that's how people living with HIV have been getting their care over the last now coming to 3 months, which has its implications. The shelter-in-place orders have been extended multiple times, including March 16th. The shelter-in-place guidelines were put in the state of California on March 19th, extended on April 1st, and extended again on May 22nd. It keeps on going, essentially, and at this point, there's no unlike the first two times when shelter-in-place ordinances were put in place, there was a date that they went until, and now it sort of looks like they're indefinite with openings as prescribed. But you've see that very, very flat number of deaths really has been the same in the city for many, for essentially the whole month of May, quite flat, and our number of hospitalizations have stayed flat as well. So the cases may have gone up, but the cases go up without severe illness, which is a good thing. And then, as you know, April 17th, but it was enforced April 22nd, was the universal mask policy in San Francisco. Next slide. So are there reasons to think that people living with HIV could have worse outcomes with COVID? And that was sort of the first impulse. That was the first idea that, immunosuppression, people are going to have worse outcomes. Theoretically, yes, but we have really not seen that to date. And I think that there's been enough infections at this point, enough hospitalizations, enough deaths, that if we saw a very disproportionate impact on those living with HIV, we would have observed it by now. And I think that's a good sign. And there are a couple of reasons why. The theoretical reasons why it could be worse in those who are living with HIV. Immunosuppression itself, could that lead to worse infection? Well, that's true for other viral pneumonias. It's true for viral influenza, for example. However, immunosuppression is actually not a clear risk factor for SARS-CoV-2. And in some cases have been thought of it that it could actually help because a lot of the severe illness from SARS-CoV-2 is the massive inflammatory response and the immune system in a way attacking itself. People who live with HIV have an increased frequency, however, some of the known risk factors associated with severe COVID, and those include older age, cardiovascular disease, pulmonary disease. Obesity is also a risk factor that's come out, and diabetes. And then at least among our safety net population, for example, that we serve at Ward 86, marginal housing and SROs and places where you can't, really shelter in place from others, that can lead to more exposure. So next slide, please. There are also reasons to think that maybe outcomes could be better in those who are living with HIV. And what's the main reason that we think so? This has to be tested. This has to be understood. But the same are the polymerase, or the what helps replicate HIV is an RNA polymerase. And that is the same polymerase. It's also an RNA-dependent polymerase that SARS-CoV-2 has. And the only medication that seems to work against SARS-CoV-2 is called remdesivir, which is what's called a nucleoside analog against an RNA polymerase. And tenofovir looks a lot like remdesivir, or at least it is also an analog. It's actually a nucleotide analog. And so there's been a lot of speculation, and there's been some in vitro studies that tenofovir may inhibit the SARS-CoV-2 replication, basically. And tenofovir is the breakdown product of both tenofovir disoproxil fumarate, or TDF, brand name's called Truvada, and it's also the breakdown product of tenofovir alafenamide, which is, its brand name is Descovy. It's also in Biktarvy, and some other medications too. I can name all of them if you're interested. I mean, Simtuza also contains a tenofovir containing product, and I'll think of, they're in combination essentially with different things. So the other one's called Abefsi, and also Complera. So all of these contain tenofovir in them, and could tenofovir itself suppress the SARS-CoV-2 replication? Well, there is a ongoing study that started April 1st in Spain that's giving Truvada to healthcare workers and seeing if it decreases susceptibility to developing SARS-CoV-2. So we'll see the results of that study. But if anything, it may not decrease susceptibility, but it may decrease the development of severe disease, because we just haven't seen the severe disease in people living with HIV coming out, as a defined risk factor, along with these other risk factors for severe disease like cardiovascular disease and pulmonary disease and older age and obesity and diabetes. So that has been a good thing. Next slide, please. There are some very small studies that, have looked at some data, but they're just super small. Overall, there's just not a lot going on in terms of studies that look at COVID-19 and HIV. There's a study out of Italy. There's a study out of New York that I'll show you on the next slide. Preliminarily in our city, we haven't seen, for example, out of a case series, hospitalized at San Francisco General, only 3 out of, I think, 158 in that series had HIV, and they didn't have poor outcomes. And of the number of people tested in the city, at least as of May 20th, out of 2,280 COVID cases, 71 were people living with HIV, which is actually a percentage that's higher than the percentage of people living with HIV in the city. I mean, meaning if we have around 16,000 people living with HIV and we have 833,000 people in the city, that's not 3%, but severe disease we haven't seen. So it's, next slide, let me tell you about the situation in Italy and New York City data. In the Italy data, COVID-19 hospitalizations did seem to occur among those who were living with HIV, and there was only 47 people in this small study that was published in Clinical Infectious Diseases, that COVID-19 hospitalization seemed to occur in those who were living with an HIV an average of 10 years younger than people without HIV. But on the other hand, the majority of those individuals had one or more comorbidities that could lead to more severe COVID. In the New York City data, there was 21 patients who were hospitalized at NYU compared to 42 matched controls. And there did seem to be a little bit of higher tendency to have intensive care unit admissions or need for intubation, not luckily mortality. And again, it was such a tiny study. So I think someone, and we'll go over questions after this, but ask the question, why hasn't there been more? I think we will see more of these reports. There was one case report of an individual who had a blunted IgG response, like it took them longer to develop antibodies with HIV than people without HIV, but that's pretty much not great data. It's just, the jury is essentially pretty much out in terms of what we think about HIV and COVID. We haven't seen, though, floods of data on more severe disease in HIV, and I'm quite convinced it doesn't happen. Next slide. However, there is, of course, not just COVID, but the public health response to COVID. And the public health response, which has led to shelter-in-place dictums and stay-at-home guidelines, that has led to a terrible impact on the economy. And essentially, it really is the other way around. The concern is for people with chronic illnesses, whether it be anything, including HIV, risk factors for stroke, they are just not coming in to seek medical care as readily as they used to. And people are avoiding the healthcare system. And so the concern are that people are not dying from the virus, but they are dying from the sort of effects on the healthcare system. Next slide. So it is also really important to understand that it is profoundly isolating to be sheltering in place. And if there was already social isolation in older people living with HIV, we have just compounded that social isolation by not allowing people to get together and not allowing gatherings, and so much concern is going on about depression and social isolation. And there definitely is a kind of hotline for people just sort of are older in terms of what you can do from home. It isn't the same thing, but there are a lot of resources for older patients, and I list one of these now here. Next slide, please. So actually, I am very happy to answer any questions that you can ask live or by the chat about COVID or HIV or the interaction between each. Yeah, that's a good, okay, sorry.
Move over to Andy, and if people have questions, we can come back to them, but please feel free to type questions now and we can gather them, if that's okay, Monica?
Yes, I mean, I'm seeing, yeah, definitely type questions. I'm seeing some from Jesus, okay. Thank you, long-term survivors. Virtual hugs, because I guess we can't hug anyone anymore, and that's so sad and hard. And very good point, sorry, we're not Latinx, and that's Latinos, and even more is in 20 different cultures, but I want to be more involved in the task force. Why haven't we had more interest in the correlation of HIV and COVID-19? I actually think there's interest. It's just that we haven't seen increased susceptibility or severe disease. I mean, believe me, there's been case series after case series published from multiple settings. And the percent, like for example, there was a case series of 5,000 patients out of who from the boroughs of New York City who were hospitalized for COVID-19 in New York, which is of course a very severe hospitalization pandemic, and only 1.8% of those hospitalized had HIV, and they didn't have poor outcomes. So we just haven't seen the severe disease being higher in those living with HIV, which is a good thing. go ahead and ask questions, and I'm very happy to answer any of them.
Let's go ahead and switch over to Andy, and please continue to type questions, and we'll give Monica a chance if there are more questions later. Let me put the spotlight video on Andy.
Hi, I'm Andy Scheer. I'm a medical social worker at San Francisco City Clinic, where I work in entry and re-entry into care for people living with HIV. And I do a lot of complex insurance navigation with patients. So tonight I'm going to focus on access to HIV care and healthcare coverage during these very complex times, and hopefully provide you with some good tools that you can use to help people stay in care. I think it's really important that people know what their options are if they experience disruptions in their healthcare coverage, of course. You know, this is really something that we often see when people lose their jobs, and we're seeing a lot of people lose their jobs right now because of the COVID situation. So I think just highlighting those options is a really important thing. So thank you for being here tonight and listening to this. Next slide, please. The first resource that I want to share with you is this SFHIVCare options, and I'll put a link to this in the chat. So this is really one of the kind of key resources that we use here in San Francisco among both workers and clients to help people know what options are available here in San Francisco to provide services for people with HIV, specifically healthcare services to people with HIV. You'll see here on the first column on the left is the name of the clinic, and of course the contact information, so how to get an intake with that clinic. And then a really, really important piece on the right-hand column is the benefits information that, so these are the benefits that these clinics take. So whether they take Medi-Cal, whether they take Medicare, or whether they take private insurance, and even if they accept a Covered California, a plan purchased through Covered California, what is the plan that they take there? You can go ahead and click next, please. And so there are two sides to this document. On the back side of the document, you'll also see a small list of private practice providers. And then there's a bunch of information on the bottom of the second side that goes into detail about how to pay for care. So what are the payment structures? What are the insurance structures that are available for people living with HIV? And then also, what are some of the wraparound programs that are available? And I'm not going to talk about those wraparound programs right now, but I will give you a link to an online training that you can review. It give you a great overview of the benefits structures and insurance structures that are available for people with HIV. So go ahead and click next, please. So this next document is the HIV navigation options. So much like the care options, this is a document that was put together, and it specifically addresses if people need a little bit of additional support for navigating into care, finding a clinic, getting into care, or maybe even some long-term case management. These are some options that are available throughout the city that can help people really navigate these very, very, very complex systems that are available not only for insurance but also for care here in San Francisco. You can go ahead and click next, please. So the first side of the document has to do with navigation programs that will serve clients at any clinic throughout the city. And then the second side of this document is for folks that want to go to a very specific clinic. So for example, at the bottom here, you see if somebody wants to go to Clinic Esperanza at Mission Neighborhood Health Center, there's the contact information there for the people that can provide them with navigation support to get into that clinic. Next, please. So intakes into some clinics and private practice providers may have been certainly delayed at this time. That is changing a little bit we're starting to get back into routine care, and I think that we'll start to see people opening up a little bit more in terms of doing intakes for new clients. If someone needs to establish care right away, if somebody needs to establish care at all, I really encourage people to call your doctor or call your clinic first. So just make sure that you know what the most recent procedures are for intakes, because things have changed, and there definitely are procedures that are set in place to protect the doctors, the staff, and also the clients. So just make sure you call and check in about that before just going to a clinic. If you are having a hard time connecting, if you're running out of meds, if people want to restart care as soon as possible, you'll see these two clinics here on the on the presentation, both Ward 86, UCSF Ward 86 at General, and San Francisco City Clinic. These are really two key entry points, very easy entry points into the systems of care here in San Francisco. And you'll find the contact information on the HIV care options sheet for both of these clinics. Magnet at Strut, you can go ahead and click next, please. Magnet at Strut has also been a really, really huge help in preventing treatment interruptions for people with HIV and helping to triage people into care just after diagnosis. So they're also another really good resource that people can turn to. Again, call first, because clinics are going to want to review symptoms, and something that you're seeing happen a lot is people being asked about their COVID symptoms before they come into a place. And of course, we're always going to ask people to put a mask on when they come into the clinic. Go ahead and click next, please. In City Clinic in specific, I think it's really important that people know that we are still seeing people at City Clinic. So we are seeing people that have STD symptoms. We're seeing people who are the partner of somebody who has an STD. We're also still helping people with PrEP, helping with PEP. So pre-exposure prophylaxis, post-exposure prophylaxis, emergency contraception, and of course, helping people navigate into care. I will share also another link here that specifically talks a little bit about sex in the time of COVID. There are considerations to prevent transmission, of course, and so this link that I sent out specifically addresses sex in the time of COVID and how to reduce your risk of transmission of COVID. Okay, so many clinics, as I said, have changed procedures for getting care. A lot of clinics have been deferring a viral load, routine viral load, and other labs unless they're 100% essential to support shelter in place and to support the wellness of staff and clients. This is changing. We are starting to see a loosening of this, and so we're starting to see more routine medical care happen. So, again, call your clinic first to know what the latest guidelines are for getting medical care in person. Of course, even if things get deferred, it doesn't mean that care is completely being postponed until after we're out of this. There are a lot of efforts that are being done to ramp up telehealth to support patients sheltering in place. So telehealth, of course, is a broad term for phone calls, video, if that option is available, and other electronic communication needs. So really, this is the time to rely upon technology to stay connected with your medical providers and help clients stay connected with their medical providers. Kaiser, all of the DPH clinics, Ward 86, UCSF, they all have a version. We all have a version of something called MyChart. And this is, or they have a different kind of client portal that people can use for communications with your care teams. So utilize these, log into to the online systems or log in to the apps. Most folks have apps that they can use to communicate with their medical providers. Go ahead and click next, please. Another thing I also really encourage people to do is to use the pharmacy apps for ordering their medications. So these apps, not only can you upload your insurance information if it changes, you can order your meds, you can ask for notifications for when your medications are ready and to be picked up by the pharmacy. And then also, some of these also have pill reminders built into them. And these are really, really very, very helpful communications tools and just tools in general to use to stay on medication. Go ahead and click next. Another thing that I'm encouraging people to do is to use pharmacies that deliver. These are just two examples here of some pharmacies that deliver in San Francisco. There are a bunch of other clinics throughout the state that do delivery of medications and that also coordinate with ADAP. And I just set out a link to Magellan RX, which is the program, which is the agency that administers ADAP, the AIDS Drug Assistance Program, for the California State Office of AIDS. And they have a list on this website of the pharmacies that coordinate with ADAP and do mail order delivery. And of course, encourage people to stay in contact with your social workers and your case managers, because a lot of us have the ability to text. A lot of us are using email if you give us the permission. And of course, a lot of us are available through MyChart, like I mentioned. Next, please. So let's talk about healthcare coverage. People who already have a medical provider and experience a change in income or benefits, I really encourage you to touch base with your home clinic first. So if you have a change in income, a change of benefits, call your clinic where you've normally been going and ask them for advice. Let them know that there's been a change, because there may be some benefits things to navigate through. Talk with these clinics because they either have benefits counselors already embedded in the clinic, or they will know exactly who to send you to so you can get some help. Next, please. So there are tons of ways to stay insured and to have access to medications. So like I mentioned, I can't really go into details about all the programs that are available because we just don't have the time tonight. So I really encourage you to check out some of these short training briefs that are available through the Department of Public Health's Center for Learning and Innovation. And I'm going to share in the chat a link that will take you to these trainings. And seriously, they're very brief. Each of these trainings, and there are only 4, are approximately between 5 to 15 minutes long. So these are really great ways to learn about all the options that are available for people to stay insured, because we are seeing transitions insurance for a lot of people, and you don't have to drop off meds if you lose your insurance. There are ways to access medication. Next slide, please. For people who don't get insurance through employment, through Medi-Cal, through Medicare, or by another means, we have the Covered California Health Insurance Marketplace. It's important that people know that there are now subsidies in California for up to 600% of federal poverty level of the modified adjusted gross income. Covered California has extended their open enrollment period. It ended on January 31st. Because of the COVID situation, the open enrollment period for Covered California has been extended until the 30th of June. So there's still time to get enrolled in private health insurance through Covered California. Next, please. This is where you apply for Covered California, coveredca.com. There's also a phone number if you want to do it via phone. It's actually, I find the phone system to be very helpful. Here's a little bit about eligibility. Go ahead and click next. And also just a reminder, and you'll see it if you watch these training briefs, that many people think that Covered California is just completely out of reach financially. If someone earns under 500% of federal poverty level of modified adjusted gross income, they can enroll in a program called OAHIP, the Office of AIDS Health Insurance Premium Payment Program, and have their premiums paid. OAHIP will pay up to $1,938 a month in health insurance premiums for people who earn under 500% of FPL. So really great program, great way that we keep a lot of people insured with private insurance. Next, please. So the alphabet soup you see here refers to all the programs that are offered by the California State Office of AIDS. These programs help pay for medications and health insurance premiums. Next. So clients who were set to expire with ADAP and with OAHIP and with these other programs, there's a frequency of enrollment and re-enrollment. So basically every 6 months, someone has to show their continued eligibility for these programs. Clients who were set to expire between March 1st, 2020 and August 30th, 2020 have been set by the State Office of AIDS to their eligibility has been extended until the 31st of August. So a lot of people really should have expired their eligibility, but that eligibility has been extended automatically. So there's been an exemption in their need to do re-enrollment. For people that are enrolled in OAHIP, this is the health insurance premium payment programs, their eligibility has been extended until the end of September. Next, please. So new and re-enrollments. We have a mechanism to enroll over the phone or via email for these programs. Normally you have to be face-to-face with an enrollment worker, but now there are mechanisms so that people can do this via phone or via email to support social distancing and maintain people in isolation and protected from the virus. So call your ADAP enrollment worker, or you can also call the ADAP hotline, which is seen here, the 844-421-7050. Another change is that people can use their 2018 tax return until the middle of July. Normally, once the tax deadline of April comes up, you have to use your tax return for the previous year. Now you can use your tax return from 2018 because the tax return deadline for the feds has been extended until the 15th of July. Next, please. If you need help finding an ADAP enrollment worker, there is a link here you see on the screen. I'll also send it out in the chat. This is a way to find an ADAP enrollment worker. It's basically a map that you can use to search to find an ADAP enrollment worker. Folks, there's also a really great new feature that the Office of AIDS has implemented, which is that clients now can have access to the ADAP portal so that they can log in and they can see what their expiration date is, and they can see the payments that have been made to insurance plans through the OAHIP program. And for access to that, there is a really wonderful blog post that was that PRC did. And I just sent that out in the chat so you can grab that information. You can read more about how to access the client portal. Next slide, please. Medi-Cal, CalFresh, and the County Adult Assistance Program. So Medi-Cal is free insurance for low-income California residents. CalFresh is otherwise known as food stamps, and the CAAP is also known as general assistance. Go ahead, next, please. Here, so the Human Service Agency, this is the agency in the city that administers these programs. They're closed to walk-ins. Phone, email, fax is preferred. They will do some face-to-face appointments if necessary. This is mostly for people who don't have a phone, don't have a way to be contacted. So you can also call the Human Service Agency to find out what's going on with your application at this phone number here. Next. The best way to apply for these programs these days is really to do it online through mybenefitscalwin.org. Next. And just a note that, of course, Medi-Cal, it's a little bit of a process to get enrolled. They usually take They can take up to 45 days to process an enrollment. Sometimes it even drags on a little bit longer. So ADAP program, the ADAP program will pay for medications while somebody's waiting for their Medi-Cal to be approved. So please utilize all of these programs to stay insured and to have coverage for medications. These are definitely times to be proactive and to advocate for yourself. So if a worker doesn't call you back, I really encourage people to call them again. We love you, we want to hear from you, but sometimes, like I mentioned, procedures change a lot lately, and sometimes, you know, we're human and we miss a text message or an email or voicemail. So please be proactive. And next slide. Also, so this address, you'll see I'll send that out in the chat as well. There are new income caps for 2020 for Medi-Cal, for CalFresh, and for other programs. And so they are found at this tiny CC link. Okay, the next slide. And that's my contact information. So if you have any questions, feel free to contact me. Thank you.
Andy, I know there were several comments, a couple of questions. I don't know if you want to address anything right now or wait till the end of everything.
Let's see if I can scroll through them right quickly here.
Okay.
If what you're saying is true. So when I mentioned that we are seeing people at San Francisco City Clinic for STDs, it's important that, so we're not just doing routine screens, so people need to have symptoms of an STD. So they're having symptoms of an STD, the drip, the burn, or the sore, or they have to have a partner who was diagnosed with an HIV, and so they need treatment as a contact to an STD. Those folks are usually called in. But, you know, always call the clinic first, because we are actually triaging a lot of people over the phone at City Clinic, and we're even doing some treatment over the phone. So people may be able to describe symptoms, and if they have an insurance product, we'll just call in medications to their pharmacy. Let's see. The bureaucracy of HIV/AIDS has increased at high levels, including elements like ADAP. Yeah, I think that in general, regarding the bureaucracy for ADAP and all of these other programs, I think actually, so these are requirements that are coming out from the federal government. So, and I really think that the state has done a lot to manage this as best they can, and is really, I think doing a great job at giving us a lot of flexibility and a lot of ways, not really around these requirements that the federal government is putting up, but giving us a lot of ways to respond appropriately to the requirements that the federal government is putting out. Yes, we do have to recertify for the ADAP or for OAHIP or these other programs twice a year. We have ways now that we can do it using this client portal. So it's a really valuable resource, I think, this client portal, and I think that the State Office of AIDS has been really responsive to a lot of advocacy efforts that my colleagues and I have done to make sure that there is more flexibility and that we're responsive to patients' needs in light of some of these strict requirements that are set forth by the federal government. So I think that we're doing pretty darn well, and if you're having challenges with obstacles to some of these programs, reach out to your social worker, reach out to your case manager, and find an ADAP enrollment worker who really knows how to work with the requirements of the program and keep people maintained in care and in these programs.
Just in the interest of time, let's move on there. I know we're just a little late in the program, but we're still pretty close to on time, and I want to make sure our last two presenters have time
Thank you.
to get to their presentations. So Negin, I'm going to turn to you now.
Okay. Everyone can hear me okay? Hi, everybody. Good evening. My name is Negin Mohajeri. Thank you so much for having me. What I'm going to talk about today is just some of PRC services. I'm going to try to touch on COVID changes. We're a little limited on that information. I'll talk about that as we get there. But I guess we could go on to the first slide and I'll just talk about PRC and who we are. So we service individuals living in San Francisco. I have a number from 2018. I wish I had 2019, but we serviced about 5,419 individuals living in San Francisco, mainly HIV positive, people with mental health issues, people that are homeless, people at risk of being homeless. We started as the benefits counseling program, which is part of our legal advocacy arm, and then expanded over the years. Now we have a number of programs, including the legal advocacy. We have employment services, and we have emergency financial assistance for people that are HIV positive. Today, I am going to be focusing only on the legal advocacy program, which recently, as I said, it started 25 years ago. It recently expanded about 6 years ago to include EAHP, which is our Equal Access Healthcare Program. We could go into the next slide. So EAHP, I just want to give a little bit of a disclaimer. I'm actually not on the EAHP team. So after I do my brief overview, if there are any questions that I can't answer, I will be providing information for Jason Sink-Mars. He's our supervising EAHP attorney, and he would be more than happy to answer any of the EAHP related questions. And I think Andy touched on some of the healthcare stuff too. So there might be a little overlap, but I think that, you know, I'll do my best here. We can go to the next slide. So the EAHP program, it launched in 2014 after the Affordable Care Act, ACA, passed. The city had a health reform task force, and they had asked us to identify issues that might start coming up after the law had passed, particularly for people who are HIV positive. Our EAHP program is funded by the SF County, and the goal is trying to get healthcare access to everyone, and that may look different for different people. But nonetheless, most people have barriers of some sort, and we try to help them work through, specifically through counseling, advocacy, and training. We primarily help HIV positive residents at 500% below the federal poverty level, as well as the community providers who help these populations. We can go to the next slide. So there are 4 different ways we help service people. The first is consultation. Individuals may not need legal representation, but they may just have healthcare related questions. And we help answer them or direct them in the right place. If it seems like they might need more assistance, we might have them come in and intake them and provide legal representation. And with the legal representation portion, a lot of what we do is help coordinate and enroll people in the different programs they might be eligible for to best serve them or their particular circumstance, which can be ADAP, could be OAHIP, could be getting them on a better Medicare program. There's a lot of different things we try to, or barriers we try to help them navigate around. And I'm going to type in the chat. I'm actually going to provide it at the end, but I did want to give the information for calling in for either consultation or legal representation. You're going to be calling the main line and asking for Kali Leal, and then you're basically letting them know you're a patient or a provider and you have a healthcare access issue. What we also provide is some community outreach and trainings in the community to help people navigate through the healthcare system. as well as some policy recommendations. We've been doing some work with Getting to Zero, which I would assume a lot of people here know, but it's the big initiative in the city that trying to get people to zero new infections, zero stigma, zero new deaths. So we could go on to the next slide. Just wanted to identify some of the most common issues for EAP that usually are the basis for people contacting us and initiating service. Denial or discontinuation of Medi-Cal, people having really high co-pays or the plans they're currently on not best matching the services they need for the specific issues they're dealing with. So they're just paying unnecessary out-of-pocket costs. Situations where people have lost their job and losing their insurance, which is something that could be especially relevant right now during the COVID pandemic. But as I'll later discuss, we kind of don't know that just yet. Situations where people who are now Medicare eligible and don't know what their options are, and people who are being denied essential services for their specific medical needs. We could go to the next slide. Well, this is just pointing out that we're going to benefits counseling. It's the next arm of our legal advocacy. And when I say benefits counseling, we're talking disability benefits. Just an idea of the numbers in 2018, we did 1,000 intakes, about 913 consultations, and many more trainings. The goal, I'm just going to read this because it's a little bit of a tongue twister, providing comprehensive, specialized, culturally competent free benefits representation within a harm reduction and client-centered context, emphasizing one-on-one relationships. We do have some different contracts that service different individuals, all of which have to be San Francisco residents. We have a care contract that's for HIV positive or AIDS having clients. These individuals can refer themselves. Our CBHS contract is for people with mental health disabilities. They do need a referral from a recognized mental health provider. We have a smaller contract with the Mayor's Office of Housing and providing services to individuals with disabilities who are part of a household. And then another smaller contract with Tipping Point to provide services to homeless individuals or at risk of being homeless individuals. Usually we could find eligibility to fit someone into one of these particular contracts. I mean, it covers a lot. And again, I gave that front desk number in the chat, but you could always contact the front desk. If it's just a question, you ask for the officer of the day. One of our staff attorneys will usually get on and answer the question. And if it's someone needs an intake, if they need more assistance, you could call the front desk and just ask to speak to one of the legal assistants, and they'll usually go ahead and schedule an intake. We could go to the next slide. Okay, so again, we're providing advocacy and legal representation for public disability benefits, but this can look like a variety of things. So there's supplemental security income or Social Security disability insurance, which SSI or SSDI, and I feel like that's what most people are familiar with when they think of disability benefits. We help individuals navigate the entire process through either of these programs. We also do CAAP advocacy, which is for individuals who, because of their immigration status, are not eligible for SSI. This has been a little tricky in the last few years with public interest issues with the Trump presidency. We've been seeing a lot less CAAP advocacy just because a lot of nervousness if people don't specifically know their immigration status, and not wanting to bring attention to people if they're asking for public benefits. We also advocate for people that are facing cessation of benefits for what they call continuing disability reviews, or a CDR. That's people that have already been approved on one of the other programs, and after a certain amount of time, Social Security basically says, hey, we're reviewing these benefits, are you still disabled? With all of this advocacy, we are focusing primarily on the medical determinations, meaning we're trying to get people medically approved by gathering medical records, by working with their providers, etc. There's ways to not be found eligible for Social Security benefits for non-medical reasons, for example, income or assets. And we may give advice in these situations, but we are mainly focused on medical determinations. We could go to the next slide. So we handle all administrative levels of the disability process, well, except for one. We do initial filing applications, we do reconsideration appeals, we represent people in front of administrative law judges at administrative hearings, and if that comes back unfavorable, we do appeal to the appeals council. This can be a long process. If someone ends up going through all these phases of appeal, it could take 2, sometimes more years. And then if an appeals council decision comes back unfavorable, that's when someone would has a decision to go to federal court. Unfortunately, we do not handle federal appeals, but we do usually refer clients out to low-cost attorneys in the area that would be able to handle federal court appeals. So just a brief overview of how someone could be found disabled, for any of you that don't know. At any of these stages, someone needs to be, one, have an impairment that has lasted 12 or more months, or is expected to last 12 months, and or expected to result in death. And the individual needs to not be working over a certain amount. And that specific amount for 2020 was $1,260 gross. So if an individual is working above that amount, they would not be eligible for any of the disability benefits programs. For those that are still working or their impairment lasts less than 12 months, Social Security disability may not be the best resource for them. They may want to look into something like state disability. And another thing to know is that you could apply for both SSI and SSDI at the same time. So if you meet those requirements, there's a few ways you could be found disabled. One of them is you meet certain categories they call listings. Basically, your medical records have to prove that you meet these specific elements of these certain categories. And if you meet every element, then you would potentially meet a listing. If there's no listing, then you could still prove disability by having your medical records show that you would not be able to, due to your impairments, work, or your symptoms from your impairments are so severe that they would keep you from performing any work in the national economy. So that could be, your medical records show that you can't hold concentration for extended periods of time. You can't make it to a job site due to pain or mental health symptoms. You may need excessive breaks during a work shift to manage your symptoms. So it could be a variety of things. And then an additional consideration is when people hit ages 50 and then again 55, the law does recognize that it becomes a little more difficult to become retrained to work, to do work that might fit your particular limitations. So that might make being found disabled a little easier. Okay, we can move on to the next slide. All right, so COVID issues. This is obviously since March of 2020, we've been dealing with this global pandemic. And I think I mentioned this earlier about EAHP. it's odd, but we don't really know what people's healthcare coverage issues are. We're dealing with a lot of people staying at home, not wanting to go to the doctor. So they haven't really been reaching out to us as much. And so this might be something that we will see in the future. We'll actually know the impact, but right now we're kind of in the dark about COVID and how it's related or how it's affected our EAP clients. As for the benefits counseling portion, we're seeing a lot of different aspects being affected. All the Social Security offices are currently closed, which has made it really challenging for our clients because usually they would go in to file, or if there was any information they had to provide and gather or get documentation from the Social Security office, they can't do that in the same way. And it's really hard to get people on the phone right now. I'm talking to clients who have been on hold from 45 minutes to a couple hours just trying to get someone at the Social Security office on the phone. So that's been proving really challenging for individuals who've been scheduled or are to be scheduled for the in-person administrative hearings. Well, all in-person hearings are postponed and they're being given the option to do the hearings telephonically, which for a lot of our clients, for some of our clients, telephonic option is fine, but for some, it's not a great option because there's just certain benefits there are from a judge seeing a person and someone in person. For example, if there's mental health issues at play, they could better be demonstrated in person. But if someone decides not to take the telephonic hearing option, they're not really giving us a clear date of when they would restart in-person hearings. So at this point, we don't really know how long they're being postponed for. So that's been an issue. Case development's been challenging, contact with clients, providers, people not being in their offices. Everyone's being very great in terms of just being creative. Also, just some CDRs, the continuing disability reviews, they're on hold, which is a good thing because people are staying in pay, but that's probably the only thing that we've been good, or that's proved good about the COVID issues. I think basically if we go to the next, I know you need me to wrap up, Jeff, so this is some contact information. I said that I would provide the supervising EAP attorney's contact, and then the main line for anything else. I believe that Jeff is also going to be providing the legal director, Beth Maisie's contact information. She's always a good resource for any benefits counseling related issues. And with that, I'm done. Thank you for having me.
Thank you so much, Negin. And yes, Beth's contact information is on the front of the slide deck and the end of the slide deck, which I will be sharing. And as a former EAP attorney myself, I will echo what Negin said and really please contact them if they can help in any way, because EAP attorneys are very creative in trying to address the healthcare issues of people. And that team is just fantastic.
Thank you, Jeff.
So Bill, let's go over to you now.
Great. I know that our time this evening is limited, so I'm going to just mention a couple issues and maybe we'll have a couple minutes for questions. I know that Jeff has my slide deck available for folks. I want to thank Jeff and Bailiff for putting on this forum. I think it's really important to get information out to the community. I want to thank Dr. Gandhi and folks from our sister agencies who are on the front line serving our clients for all of their work. And I want to acknowledge the work of ALRP's staff attorneys, a number of whom are on the Zoom this evening and can be a wonderful resource for the community as well. I'm sure many bailiff members are aware of the long history between ALRP and bailiff. It was bailiff attorneys who started the AIDS Legal Referral Panel back in 1983. We provide legal services to people living with HIV in 7 counties around the Bay. We can assist people with a pretty broad array of civil legal matters. So I'm just going to touch on a couple things: housing, immigration, unemployment insurance, our HIV consumer advocacy project, and hit volunteer opportunities as well. And I'm going to do it in record time. Watch. So folks are aware that there is a ban on evictions, and I want to try and break that down for folks very quickly. First, there is a ban on evictions where the issue is the loss of income related to the loss of a job related to COVID. There's also a pause on evictions in San Francisco and other counties as well. I fear that many people believe that this ban on evictions somehow negates the requirement to pay rent, and that is not the case. It will, however, be the case that folks will have additional time to pay back rent that is owed. But the other thing that is important to know is that there are evictions that are moving forward. Those relate to when the landlord asserts that there is an exception to the ban related to a health and safety challenge to other tenants or to the landlord. And that can be a tricky process because there can be hearings that move forward without notice to tenants. For many of these issues, it is essential that folks have access to a qualified attorney. ALRP has a robust eviction defense team. If you have questions, please reach out to ALRP. Our contact information is included in the slide deck. For immigration, for the most part, the immigration courts are closed for hearings, but there are a number of procedures that are moving forward. ALRP can provide assistance with a range of immigration legal issues for many of our clients who are fleeing persecution from other countries. Immigration issues like political asylum can be a game changer for them as they try and integrate into a new community. Unemployment insurance, people are aware that there are additional benefits when the issue is loss of job related to COVID. ALRP can provide some assistance with unemployment insurance issues. There are other legal services providers that we can connect you with as well. I want to make sure that folks know about the HIV Consumer Advocacy Project for people who are being denied services or discontinued from different service providers in San Francisco, Marin, and San Mateo counties. We have an attorney on staff who can help folks get back in relationship with a service provider because we know that those health services are very essential for people living with HIV. And then I want to just make a quick pitch around volunteering with ALRP. There are, of course, many bailiff attorneys who serve on ALRP's panel. There are a lot of perks for joining the panel, including being able to have access to free MCLE trainings, getting professional liability insurance coverage, and mentorship from more experienced attorneys on our panel. So if you are looking for a way to give back to the community, now is a great time to use your legal skills for folks who really need an attorney. And we know that attorneys can make a huge difference. I like to say, and it's true, the folks who are least able to deal with the system are the folks who are forced to deal with it the most. I think as you've heard the presentations this evening, you have a sense of how complicated things can be for people who are sometimes sick and sometimes least able to navigate these systems on their own. So that is record time. I will make sure that we have a couple minutes to answer questions. I do want to give a shout out to ALRP attorneys who are on the Zoom. Jeff Dolgar is our supervising housing attorney. Lynette Bakelig is our insurance attorney, and Carmen Ramirez is one of our immigration attorneys. Thanks.
Oh, that really was a record time, Bill. I know we zoomed through some of these slides. As a reminder, I will share the slides after with everybody, so don't feel like you had to write everything down. I'm going to stop screen sharing the slides so that we can view the presenters better. And I believe everybody should be able to see presenters now. I don't know if there were questions in the chat or if people have questions. You can also use the raise hand feature or just type questions or unmute yourself and say your questions to the panel. Bill, I do see one thing here. According to bad management companies, if they can find ways to consider you a nuisance, they can get away with evictions. Have you seen that happening?
So we certainly see evictions where there are allegations of nuisance-related behavior. If an individual is living with HIV, they should reach out to ALRP and we can connect them with an attorney.
I have a question. How can ALRP help with immigration issues?
So we can provide assistance on a pretty broad array of immigration matters, everything from political asylum to naturalization, adjustment of status, work authorization. So yes, if you're living with HIV and need assistance with an immigration matter, you can reach out to ALRP.
And from a user's perspective, I can vouch for that I've referred many clients to ALRP, and they've been connected with some excellent attorneys that have taken their case pro bono. They've been very, very helpful.
I think Jesus has a question. You indicated raise their hand.
Hi, everyone. Please, thank you for being here. I love you all. I don't know if this is too particular, Bill, but we do know, of course, that there's a huge case against Green Tree Veritas. And of course, they also got the $3 million and et cetera, et cetera. I know that you guys had many clients that they were having problems with these huge companies. Are you still doing something in particular or not really at this moment?
So we certainly have clients who have issues with the landlord and property management company that you've identified. So ALRP can do a couple of things. First of all, we can assist people who are facing an eviction. And then if there are issues that are related to habitability or to unlawful rent increases or reasonable accommodations, we can provide assistance with that as well. So if there are folks who you know who need assistance, it's always best to refer them to ALRP. We can do the initial intake and assessment and see what we can do to assist.
Recall seeing other questions in the chat. I don't know if any of the panelists have received any questions directly to them.
Oops.
One thing I would wonder if Andy or anyone on the panel knows about the public benefits programs in places besides San Francisco. I know Bailiff, for example, we have a lot of our members in East Bay.
Of course, Medi-Cal is a statewide program, and also all of the State Office of AIDS programs are statewide as well. And I shared a link of how to find an ADAP enrollment worker, and of course that's a statewide search too. So not just San Francisco centric. That's something that can be used anywhere in the state of California. Covered California 2 is a place that, depending on where you live, of course that's a statewide insurance marketplace. So you can certainly use it to find insurance in Alameda County or other counties throughout California. In terms of kind of sister agencies throughout the city, over in the East Bay at least, the East Bay Community Law Center is another one that I've often sent clients to that have moved out of San Francisco and need some legal resources, helping with a really wide swath of legal issues. And then of course, East Bay Sanctuary is over there in Berkeley, and that's a very respected, and many of my clients have used East Bay Sanctuary for their asylum cases. So those are just some off the top of my head that I can think of that might be some resources for people in the East Bay.
And ALRP, of course, provides legal services in 7 counties around the Bay, including in Alameda County. We certainly collaborate with the East Bay Community Law Center and other legal services providers, and hope to complement each other's services so that we're not duplicating services. But if there's ever a question, please reach out to us and we can connect you.
There's also the East Bay Getting to Zero coalition. They've done a really great job at disseminating information about the more medical aspect of things, and what people know. So kind of the issues that Monica has talked about, they've been really doing a great job at disseminating emails and having information on their website about COVID-19 and HIV. So that's another resource too that is in the East Bay.
Can I ask one more question? I know I always have 100,000 things. One of the things that I am very, very concerned as an HIV long-term survivor is the issue of stigma. We already have seen these issues happening already in our community of brothers and sisters of the COVID-19. Is there any preparation that you guys know about these issues? Because again, we know by now that after 40 years of HIV, stigma is still an issue, but now it's happening with this new pandemic. Is there any preparation at all for this?
I mean, I think, I think from my point of view, the COVID stigma has actually been somewhat around healthcare workers and other essential workers. And that has been really disturbing, like within families. To have a healthcare worker be stigmatized even within a family. Definitely people have just avoid people who are out working. So I think that's a great point, that we have to think about the overlapping stigma of the 2 pandemics. And this is a pandemic that disproportionately affects brown and black communities, there's no doubt. And that's why right now everything is just feeling so hard, because we're seeing this kind of racism playing out in really violent and terrible ways in this country, on top of COVID, on top of economic downturns. It just seems to be it's a very difficult time. So I think mental health right now is paramount, and any way that we can help in our clinics and in our settings to help people with mental health. I think it's really hard for people to see each other only over Zoom. I'm hoping for more guidance and opening up with time, because I think the city can afford it, in the sense that we have done really well, and I think we can start opening up somewhat. And I hope to see guidance like that for medical healthcare as well.
Andy or Bill, or if any of the panelists have final thoughts, I want to respect people's time, so we should wrap it up here.
I'm good. Thank you, Jeff.
Thank you.
Thank you for having us.
Thanks.
Great. Well, thank you so much, everyone. I will get the video out within the next day, and we will also be sending a follow-up survey. But thank you for showing up.
Thank you.
Good night,
And a
everyone.
huge thank you to our panelists.
Stay safe, folks.